So hello and welcome to the ARMA Thinking Differently for MSK Health conference. For those who are not familiar with us, ARMA, the Arthritis and Musculoskeletal Alliance, brings together patient and professional organisations to work for better MSK health and better MSK services. Before we get started, I would like to thank our sponsors who've supported today's event, but have had no control over the content of the day. Our lead sponsor, Pfizer, and our supporting sponsors, Grünenthal and Janssen. Our first ever ARMA conference was last year, and we had to move it online because of the pandemic. And I was a little bit concerned that people might not be able to attend as the NHS was under such pressure. But they did, and we had a fantastic day with lots of engagement. This year, it feels as though the NHS is under even more pressure than it was a year ago. And our members report that private practitioners are also busier than ever. And in that context, I would like to thank absolutely everyone who has taken the time to join us today, as well as those who managed to find the time to watch the sessions on catch up. I'd particularly like to pay tribute to our speakers and our chairs. Many of them are involved in the restoration of elective care in various ways, and some of them were last week catapulted into a massive increase in the delivery of booster jabs. Thank you very much, all of you, for making the time to do this. And I think that really shows the commitment of everyone here to improving MSK services and the lives of people with MSK conditions. Everybody here understands the importance of MSK health. It's fundamental to our ability to move, to be independent, to work, to play, to keep the rest of our bodies healthy. Poor MSK health has a massive impact on individuals, on the NHS, on the economy, and on families. And to drive this cost down, we need excellence in MSK services. And we all know that these services were not getting things right before the pandemic. MSK often felt like a forgotten service, never getting the recognition that it deserved, given its importance, and never getting the priority that it merits. In the last 2 years, I've seen a massive shift in the priority and the status of MSK. It has been fantastic. Increasingly in meetings, I hear, for instance, NHS staff saying, people with long-term conditions such as diabetes and MSK. Before, MSK would never have been in that list. 2 years ago, there was no MSK programme. Now we have Best MSK Health. 2 years ago, when there was a focus on MSK, it was generally on orthopedics or first contact practitioner, and very siloed. Now we have the GIRFT rheumatology report, putting the profile onto rheumatology. We have an understanding that restoration of MSK services has to be a cross-system approach, primary, community, secondary, all working together, along with local authorities, the voluntary sector, employers. The whole package is crucial to people's MSK health. And it's been great to see that increasing recognition of things that ARMA has been talking about for many years, such as prevention and the importance of self-management. We called this conference Thinking Differently because that is what we need to do. It wasn't working well enough before the pandemic, and it's really tough now with healthcare professionals stretched to the limit and beyond. It's even tougher for people who are living with MSK conditions. Many of them are waiting longer for treatment than anyone would have considered acceptable in normal times. Some of them also know that they're among the most vulnerable to COVID because of being immunosuppressed. In the face of all of this, you are willing to join us today to talk about what thinking differently for MSK health looks like. That thinking differently part is what will move us from our current unsustainable pressure. And it's also what will move us to a place where in the long term, people with MSK conditions can lead the lives they want. Where the long waits for treatment and the delays in diagnosis that existed before the pandemic are reduced. And where the MSK health of everyone is maximised throughout the whole of their life. That is ARMA's vision, and it will take the efforts of thousands of people to make it a reality. But despite everything, I feel optimistic that thanks to the efforts of all of you and many others who are prepared to take the risk of thinking differently, we can get there. We have a real breadth of attendees here today across all 4 nations of the UK, including people living with MSK conditions, the voluntary sector, industry, and public health. And it is by working together that we will succeed in making that vision a reality. So please enjoy today. And I'm now going to introduce the chair for this morning, Chris Mercer. Chris is a consultant physiotherapist, and he leads the Best MSK Health workstream on primary and community services. So Chris, I'm going to hand over to you to run the morning session. Thank you.
Thanks very much, Sue, and great introduction, and really puts MSK at the forefront and helping us to realise these opportunities. As the lead for that Best MSK programme, I'm really excited by the programme I'm chairing this morning, which does look at thinking differently and looks at the aspects of supported self-management, long COVID prevention, and us thinking differently. So it's a really nice link to what we're doing in the Best MSK Health programme with the support from ARMA. We've got some great speakers this morning, and I'm going to move to our first speaker, who's a man with a big job on his hands, Steve Powis, who's the National Medical Director of NHS England and NHS Improvement and Professor of Renal Medicine at UCL. Steve's going to talk to us about restoring MSK services sustainably, which I'm sure we're all really interested in and is vital for us moving forward. So over to you, Steve, and thanks very much for joining us.
Well, thank you, Chris, and thank you, Sue. It's very kind of you to extend the invitation to me to speak today. And of course, first of all, I want to say a huge thank you to ARMA and indeed to Sue and all her colleagues for all the support and the collaboration across a range of really important programs for us, from Best MSK to, as you've heard, the vaccination program. The NHS family is far more than individual NHS organisations, and we know we couldn't do our work anywhere near as well without partners such as ARMA. This morning, I'd like to give some reflections on the NHS pandemic response so far, and then move on to how this is shaping the future of services, and specifically say a few words about MSK services. I'm sure everybody on the call today will agree that it certainly has been a remarkable, well, nearly 2 years now, remarkable 22 months. Personally, I've been overwhelmed by the passion, the focus, the dedication, and to be honest, the sheer determination of colleagues throughout the NHS and beyond as they have responded to the pandemic. Everybody working together to ensure that patients with COVID, and of course those without, have been able to receive the care that they need. I'm very conscious of the extreme pressure that the entire clinical workforce has been under, and how this has sometimes seemed unrelenting as we've managed patients with COVID and worked to clear backlogs that have resulted from the pandemic. I know that many services have seen a large proportion, if not all, of their medical, nursing and allied health professional workforce redeployed at times to help look after COVID patients. Many of our colleagues have also made significant personal sacrifices. Families have had to live apart for extended periods. Trainees have had their studies interrupted. Staff have worked longer hours under stressful and challenging conditions, all whilst working in unfamiliar and changing environments and circumstances. So I'm in no doubt at all that our staff have carried an enormous burden during the pandemic, balancing the provision of routine and emergency care with managing acute or suspected COVID-19 patients, all while social distancing, dealing with enhanced infection control measures, and of course, staff sickness and absence. Sometimes our response to COVID has meant stepping into the unknown and changing the ways that we are used to working. It has indeed been relentless for everybody. I also know it's been frustrating for patients as well as staff to see services paused and disrupted. with the result that waiting lists have grown and clinicians have been unable to bring their patients in for the treatments and procedures that they know that they need. And this has particular implications for those people with arthritis and MSK conditions. And I know that the MSK and arthritis community has specifically stepped up as part of the COVID-19 response. Versus Arthritis and ARMA in particular have helped produce guidance, have supported vaccination uptake, and they're now working with the BEST MSK health programme, My Plan Care and Chronic Pain Steering Group, all of which will be really important as we seek to address elective care waiting lists. You have been integral to all our work in NHS England, and of course to Andy Bennett in particular in his role as the National Clinical Director for MSK. So, as I've said, first want to pay tribute to all those involved who have contributed and collaborated as a professional, through a patient group, or through indeed any other way. A huge thank you. Now, I'm sure like me, you will have been reflecting on the last 20 months, what has gone well, what could have gone better, and what we have learned as we have gone through this pandemic. I'd now like to touch on several aspects of the pandemic response that have particularly struck me. The first of these is the flexibility and agility with which the NHS has responded. Over the course of the pandemic, the NHS has shown just how quickly it can adapt and move to new ways of working to support patients and the public. Whether it's been in the development of the Nightingale hospitals, in the tripling of our intensive care capacity, in the changed and extended roles that many staff have taken on, the rapid establishment of clinical trials that have identified effective COVID treatments for use across the world, or indeed the rollout of the biggest and fastest vaccination programme in our history. I believe we have seen the NHS at its best. My second reflection is that emergencies require innovation, and we have certainly seen plenty of innovation over the course of the last 2 years. Thinking Differently is a title of your conference today, and it's something that we've had to do a lot of in the last 2 years. We have, for instance, seen the development of many new clinical pathways, the remote monitoring of patients at home, improvements in non-invasive ventilation and the way machines work around ventilation, and the deployment of clinical trial outcomes at rapid pace and at scale. The pandemic has truly changed the way that all of us work. So the task now is to capture the innovation that has worked best for our patients and of course for our workforce, and to make sure that we don't simply revert back to our old ways of doing things. We are still keen to hear examples from you of how MSK practice has changed for the better, the things that you wish to take forward in primary, in secondary, and in community care, in rheumatology and diagnostic services, across spinal services, or within orthopedics. Third, I'd like to highlight the role that science has played in the response to the pandemic. Nearly a year ago to today, that was on December the 8th last year, I was privileged to be in a cold and foggy Coventry to witness Maggie Keenan become the first person to be vaccinated outside a clinical trial with an approved COVID vaccine. You know, it really felt like an historic moment at the time, but that sense of history was really brought home to me just a few days later. When I left Coventry at the end of the day, I took with me the vaccine vial used for that first jab. Of course, as you would expect, with the permission and with the cooperation of the team in Coventry. A week or so later, I delivered it to the Science Museum here in London, handing it over right in front of the display that tells the story of vaccination going back to Edward Jenner in the late 18th century. As I gave the vial to Natasha McEnroe, the keeper of medicine at the museum, it was immediately transformed from an ordinary glass vial to an historic artifact. And of course, handled by the museum in exactly the way you would expect for an item of historic importance. Something that people will almost certainly be viewing at the museum for hundreds of years to come. Now, this time last year, it would have seemed highly optimistic to predict that COVID vaccines would be so successful, and by now would have administered to over 90% of over 16s in the UK, with over 80% of people fully vaccinated. But that, of course, is exactly what we have achieved because of the huge scientific advances that have been made in recent years in areas such as genomics, areas such as sequencing, in vaccine technology, and in data processing. This has been a truly international scientific and clinical effort, within which, of course, UK scientists have played a major role. And of course, the NHS across the whole of the UK has done an absolutely incredible job in deploying our biggest and fastest ever vaccine programme, which of course, as Sue said at the start, continues apace with the renewed emphasis on boosters. Last December, when that first jab was given, I remember saying that it felt like the beginning of the end. I still think that's true because vaccines are one of our main ways out of this pandemic. Therapeutics are now coming along as well, but there's no doubt vaccines are our initial key out of the pandemic. Though with infection rates still high, as you know, it's certainly true that we still have a road to travel on that journey. So when you get your call for boosters, please make sure that you come forward too. Next, I'd like to reflect that science and public health has been thrust into the public debate in a way that I can't recall witnessing before. Medicine and science have certainly become part of the daily national conversation. It sometimes seems that everybody has become an armchair epidemiologist, carefully watching that R number change from week to week. In my role as National Medical Director, I have always worked closely with ministers, with politicians, with civil servants to develop and deliver health policy. And of course, I've often made appearances in the media. To be frank, it's part of the job. But in the last 20 months, senior clinical and scientific leaders, such as myself, have been thrust into the public limelight in a quite unprecedented way. I'm sure you'll agree that one of the most obvious examples of this has been those regular Downing Street press briefings. To date, I must have participated in around 35 of these. Well, although at times a little bit surreal, it has for me been a real privilege, a real honour to be able to speak directly to many, many millions of people live on television. My aim throughout has been to tell it as it is, to reassure, to educate, and to inform, always providing clarity and simplicity to complex clinical and public health questions. And of course, to focus on the medicine and the science, leaving the politics to the politicians. Now, that's easy to say. It's not always easy to do. But I do hope that all of us who've appeared at those briefings, the Chief Medical Officer, Chief Scientific Advisor, Susan Hopkins, JVT, all of us have at least in part accomplished those aims. And of course, it's not just at national level that clinical leadership has been so crucial throughout the pandemic. Clinical leadership has been visible at all levels of our health system, whether it's been leading surge capacity and new ways of working in intensive care units or on wards, or in working with partners across society, such as local government, politicians, or indeed organisations such as ARMA. So I'm truly grateful for the outstanding clinical leadership demonstrated across the board, and delighted that we are now starting to see this very visible leadership translated into recruitment of new NHS staff and increased interest in careers across healthcare, such as people interested in coming to do medicine or nursing. Now, my final reflection is that the pandemic has brought into sharp focus the commitments made within the NHS England long-term plan, published, as you remember, at the start of 2019. Pandemic has really, for me, emphasised the need to concentrate even harder on the plan's key elements, on prevention in areas such as obesity, on reducing health inequalities, on key disease areas such as cancer and mental health, on the need for digital innovation in healthcare, or on the plan's focus on partnership working across local health systems, integrated care systems, as well, of course, as the important commitments to MSK in the plan. The pandemic has indeed shone a harsh light on all of these, but also reinforced for me the rationale for and our desire to deliver on those long-term plan priorities. It's also worth remembering that while we have been responding to COVID-19, we've also been busy ensuring that we remain focused on improving healthcare and on the health of the population as a whole. Now, for me, my role at NHS England, that's meant continuing work on the areas that I have particular responsibility for: cardiovascular disease, stroke, and respiratory. And of course, those ambitions for those disease areas articulated in the NHS long-term plan. Although it's been challenging, we have been determined not to lose momentum, and we have kept going on the work in those programmes. And I'd like to pay particular tribute to our third sector partners who help lead those programmes. So that's the Stroke Association, the British Heart Foundation, and the British Lung Foundation. Another example of working with partners in the charitable sector. Now, the last 20 months, as I've outlined, have been incredibly challenging. But I'm sure you will all know that the challenges that we face are by no means over. As I speak to you today, we still have just under 8,000 COVID patients in hospital beds throughout the United Kingdom. And of course, we have the uncertainty of the new Omicron variant to think about and to contend with. As we said already, the COVID vaccination programme has that renewed focus, particularly on boosters to get ahead of that new variant, but also, of course, on 12 to 15-year-olds. And all the time, we're continuing to encourage those people who've not had their first jab to still come forward. That evergreen offer remains. Our urgent and emergency care services, as Sue said at the start, are under considerable pressure. And at the same time, we need to focus on treating patients whose care has been delayed or disrupted because of the pandemic. I'm sure you all know and realise that we will certainly be living with the effects of COVID-19 in our personal lives and in healthcare settings for some time to come. And I'm very aware, as I said earlier, that all of this is occurring, all of these challenges are with us at a time when our workforce is increasingly tired and exhausted. As I've said, our staff have worked tirelessly to see us through the pandemic. And so it's incredibly important that we continue to support them through the next challenging phases. We have to take every chance that we have to remind staff just how much they are appreciated and just how much they have achieved over the last 2 years. But it's also important that we continue to back up words with tangible support for those who need it. From simply ensuring that people take their annual leave to a more focused approach to health and well-being support, such as through our staff mental health hubs. We are very keen to support and retain clinicians at all levels across all professions. So we need to increase their job flexibility and support their professional development. At NHS England, we know that medical trainees, of course, of particular interest to me as medical director, are an essential part of the current workforce, as well as the future workforce, and delays to their training progression will have a significant impact on service recovery, as well as the personal cost to individuals. So we have been working with we've been working with Health Education England to ensure that training recovery is part of service recovery, and to encourage providers to maximise any training opportunities available. During the pandemic, a range of additional interventions have been undertaken by NHS England to support the medical and clinical workforce, and that includes the creation of medical support workers. Now, medical support workers are a new clinical role for qualified doctors who are not currently on the GMC register, perhaps because they've been out of clinical practice for some time, or because they are, for example, refugee doctors. The role of medical support worker allows doctors to gain some of the experience they need to obtain GMC registration. So far, we've had around 400 medical support workers that have been employed across healthcare organisations in England. And that's been in diverse clinical settings such as intensive care units, acute medicine, primary care, and mental health. So I'd encourage all of you who work in the health service to look out for the medical support workers and encourage your organisations to take them on. They can certainly assist in the work you need to do, and it's a great help to those individuals who are looking to get back on the medical register. As I've also noted, clinical leadership has been crucial throughout the pandemic. And I'm keen, as always, to ensure that we are able to support the next generation of medical and clinical leaders. So with the support of the Faculty of Medical Leadership and Management, we're now in the 10th year of the National Medical Directors Clinical Fellowship Scheme. And I'm delighted that this year we've been able to expand the scheme to include a regional clinical fellowship scheme. If there are any doctors in training at the conference today and you haven't heard about this scheme, I'd encourage you to get to know about it and indeed apply. But of all the challenges that we face, I know for you at the conference today, the most pressing is almost certainly going to be the elective backlog. We are making progress despite the ongoing pandemic pressures. So in the first 6 months of this year, NHS teams have delivered almost 7.4 million elective treatment starts. That's about 90% of the 2019-20 levels. Over 1.3 million urgent cancer checks. That's over 100,000 more than the same period in 2019-2020, and over 400,000 more than last year. And almost 11.4 million key diagnostic tests. That's 97% of 2019-2020 levels. But we know that there is so much more to do, and we have to accelerate the progress that we're making in waiting list reduction. If we can't achieve this, then we will see increased morbidity from those treatment delays. And I know that that is something that I don't want, and something that none of you want to see either. Post-COVID, there are huge opportunities to utilise the existing national NHS quality improvement programmes to support clinicians to restore and optimise delivery of the very best MSK care. I know the best MSK health programme team, in collaboration with the Getting It First Right team, are working hard with ARMA and other partners to coordinate and co-produce our strategy to reduce variation and to overcome any local barriers to improvement, allowing the rapid sharing of best practice and innovation to restore and optimise MSK services. In England, a large range of initiatives are now being implemented to support elective recovery, to ensure we have effective demand management and to increase the efficiency and effectiveness of our elective care pathways. So, for example, in hospitals, the high volume, low complexity program using getting it right first time outcome metrics is at the vanguard of these initiatives. And it's really focused on orthopedic and spinal services, along with a number of other clinical pathways. Our diagnostic transformation program, including the creation of new community diagnostic hubs, will also provide increased diagnostic capacity and digital improvements, which are really going to be key for the management of MSK going forward. This will be crucial to improving the quality of care, the volume of operations and procedures that we can do, and to ensure timely interventions. It's important that we also improve the management of patients in primary and community care, ensuring that the right patients are referred into secondary care at the right time, and that they then receive high quality, timely rehabilitation, releasing capacity and staff pressures. We also have to continue working with the independent sector, with whom we have worked closely throughout the pandemic, to ensure that we are using that sector's capacity as optimally as possible. We must support those waiting for MSK-related surgery and procedures to stay well whilst waiting, and therefore achieve the best possible outcomes, which is what My Planned Care aims to do. And we must deliver timely, personalised rehabilitation plans, including supportive community self-management services to help people to manage their symptoms and their rehabilitation. All these programs sit alongside a range of other initiatives, too many to mention, but they include our evidence-based interventions program, our supported self-management approach, outpatient transformation, and our work on shared decision-making. Now, I know that many patients' conditions will have deteriorated during the pandemic, requiring longer appointments and perhaps more complex interventions. And yet, as with the response to COVID-19 so far, the enthusiasm and energy that so many have contributed and are continuing to contribute to the elective recovery program, and the vision that they hold for a better future is incredibly humbling to me. So, in summary, once again, I'd like to thank all of you for your vital contribution over nearly 2 years' worth of the pandemic, and of course, all the contributions you continue to make as we continue to face the challenges of the pandemic, whilst at the same time recovering those services that have been disrupted. Yes, there are no doubt difficult times ahead, but I, for one, remain confident that we will all once again be able to rise to the challenges we face, so that as long as we think differently and do it together, I remain optimistic. Thank you.
Steve, thanks very much for opening the conference today and for such a great introduction. And I think what you allude to there speaks to a lot of what's coming in the programme later, with some really great examples. If you've got 5 minutes for a couple of questions, if I can pop a couple of questions to you. There's one from Oliver Coburn. Good morning, Stephen. Thanks so much for your talk today and your leadership throughout COVID-19. Here. You made a point about the public and media commentary on science and medicine. Do you think the UK's response to the pandemic would have been enhanced by higher levels of health literacy amongst the general public? And if so, how do we address this to protect us from future pandemics and health emergencies?
Well, I don't think this is just an issue for the UK. I think it's probably an issue for all nations, that the better health that the population is in, I think the better they are able to face some of these challenges in infectious diseases, obviously. So I noted, during my talk, I talked about obesity. We know that that obesity is related with it's associated with poorer outcomes from COVID. And so having a focus on reducing obesity is a great example of how we can have a healthier population that is more able to manage pandemics such as this. Health inequalities I also alluded to, and unfortunately we know again that COVID has hit some of our most deprived communities hard. So I think all of these things, in whatever country, having a healthy society certainly gives you more resilience against pandemics such as COVID.
Thanks very much. And we've probably got time to squeeze one more in. I think it's from Kez Mahmood around the involvement of the pharmaceutical industry, and given the vital role they've played in the response to the pandemic so far. How do you think the pharmaceutical industry can stay involved and play a vital role moving forward? And how do we optimize that?
Well, of course, the pharmaceutical industry has been involved through that incredibly fast development of vaccines. And of course, the messenger RNA vaccines and the adenoviral vaccines that we've been using are really, we should remember the first time those vaccines or that technology has been deployed at this sort of scale. So we've really had breakthrough developments in vaccines, but it's not just vaccines. I just hinted at therapeutics. I didn't say much about therapeutics during the talk, but we now are in a position where we have drugs coming to market and getting their licensing from regulatory bodies, which are designed specifically to combat COVID-19. And I said a year ago, just over a year ago, we'd have been astonished at how far we've got with the vaccine program. Well, I think the same would be true in terms of some of the results that we are beginning to see from the new drugs that are coming through. So molnupiravir, the drug from Merck, was given its license by the MHRA a few weeks ago. We are looking to deploy it shortly into the UK, and there's a new drug from Pfizer, which they've announced results on, which prevent hospitalization when it's given to people in the community to a level of almost 90%, which if that holds true in real life settings, I think is going to be really incredible. And I don't think any of us at the start of the pandemic would have predicted that we would have got so far so quickly with therapeutics, with drugs designed for a new virus and indeed for the vaccine. So I think the pharmaceutical industry has really stepped forward and played a huge role and developed these at pace, and of course are making agreements so that some of these drugs can be produced as generic drugs in countries that are not so rich as those in the developed world. So I think, yes, pharmaceutical companies have really stepped up, and I'm sure will continue to do so.
Great, thank you very much. And I've been warned by Sue that I need to run to time, and I know, Steve, you're a very busy man and have delayed another meeting for this. So I'd just like to say thanks on behalf of everyone this morning for you making the time and for your leadership through the pandemic, and keep up the good work. And thanks very much on behalf of ARMA and the Think Differently conference.
Thank you, Chris.
Thanks very much. Thanks a lot. Thanks. Some of you eagle-eyed people will have noticed that one of my kind colleagues brought me a coffee during that, so apologies for that, but I will tuck into that as we move through the morning. So we're going to move on to the a mixed session now, where we have three groups of speakers. We have 5 speakers with 3 presentations. So we're going to start with Chloe Stewart. Excuse me. So Chloe's a health psychologist working previously on the South Coast, but she's the national lead for the Best MSK Health Programme, Personalised Care Workstream, and National Clinical Specialist Advisor for MSK. So Chloe's going to talk to us around self-management of long-term MSK conditions, which, as Steve's alluded to, is vital. So Chloe, over to you, and I think Sue's going to move your slides on. So thank you for joining us, Chloe.
Thank you so much, Chris. Yeah, I've got some slides to share with you today. Hopefully they are going to go up on the screen. So thank you very much to ARMA for this invitation to speak today to you all at this wonderful conference. As Chris said, my name is Chloe Stewart, and I'm a health psychologist with a specialist interest in health coaching and behavioural science. I'm the clinical lead for personalised care within Sussex Integrated Care System, and I've recently taken on a role within the Best MSK Health Programme as a national clinical advisor in personalised care. So I hope to share with you today over the next 15 minutes what I think underpins quality self-management support and our ambition within the Best MSK Health Programme to ensure that people living with MSK conditions experience proactive, preventative and patient-centred care. And for me, at the heart of this is collaborative care. Next slide, please. So I'm sure many of you will know that the supported self-management is part of the NHS's long-term plan and commitment to make personalised care the norm. And in this presentation, I will use supported self-management to mean the ways in which healthcare services encourage, support and empower people to manage their ongoing physical and mental health conditions themselves. So this sits within a wider model of personalised care. Next slide, please. I'll keep moving on just to keep with time. Thank you, Sue. So what is personalised care? Well, it was one of the 5 critical change areas that was outlined in the NHS long-term plan back in 2019. And simply it means people having choice and control over the way their care is planned and delivered based on what matters to them. So to me, this is about delivering care, support or treatment with compassion, with dignity and respect, and delivering it in a way that enables people. So it really focuses on people's strengths and supports them to build on these. The aim essentially is to create a shift away from paternalism, where the system and the clinician decide what a person receives, to one where a person is seen as an equal partner in decision-making and care is tailored to their individual needs and preferences. We know from the evidence that this creates better health and well-being for individuals, better experiences of care, and ultimately a more sustainable NHS. Next slide, please. So why do we need more personalised care? Well, we know that what informed patients want and what clinicians think they want are often very different. And what we've seen from multiple surveys across multiple settings is that nearly 40% of people don't feel as involved in decision-making as they want to be. That 59% of people don't feel they have enough support to manage their condition. And 60% of people felt that they didn't adequately discuss the things that matter most to them, the things that are important to them in managing their condition. Next slide, please. So we know that there are many drivers for change, and while we've seen incredible advances, as Stephen Powis has outlined, in terms of curing acute illnesses, responding to traumatic injuries, and creating more treatment options, which is fantastic, we still have growing numbers of people living with long-term conditions, and a significant number of these, as you will all know, are people living with MSK long-term conditions. And these significantly impact people's quality of life. And we know that at the current time, more people that are waiting for our support and treatment. And all of this creates rising demands and rising costs, and a drive for us to ensure optimal value for all. And health equity is key. Next slide, please. When we look at what impacts on health outcomes today, we know that only a small part of this is healthcare, and that the largest impacts on people's health and well-being, as many of you all know, are socioeconomic factors and health behaviours. And while in healthcare we may have minimal control over the wider determinants of health, we can ensure that we see people within the context of their whole lives, and we seek to understand what matters to them and their health and well-being, and offer support. We also have a huge opportunity to facilitate behaviour change. And while there is growing evidence in how we do this, it's often underutilised, and we default to seeing people within a deficient model, and our response is often to give information and advice. Next slide, please. So I wanted to take a moment to focus on what we know about behaviour change. And wouldn't it be fabulous if the provision of new information led to behaviour change? Next slide, please. Unfortunately, the relationship between being given new information and enacting behaviour change is often tenuous because of a complex array of factors. And I'm sure many of you will relate to this when you think about your own behaviour and attempts to make changes. Next slide, please. There are various stages that we need to go to when we're deciding to change any given behaviour. These include being given new information, considering and appraising that information, deliberating what it means for us, and making an intention to change and then acting. Often, though, we ignore what precedes behaviour change when we're supporting people. And the key to this lies in supporting people to build motivation. Next slide, please. But prerequisite to supporting someone to build motivations for change are the relationships that we form with people. And this is the one thing that can sometimes be compromised when we feel under pressure and the system is stretched. In motivational interviewing, they outline 4 key ingredients that underpin good engagement. And I'm sure many of these will be familiar with people in the room today. They're working in partnership for and with people, seeing people as equal partners. The other is accepting people and expressing empathy. This requires us to be present, to see and to hear people, and to honour their autonomy and their right to choose. Compassion is also key, that deliberate commitment to pursue the best interests of another person. And finally, we want to draw out from people their own perspectives and their own motivations for change. Next slide, please. So in my experience and in working across a number of teams over the years, I know that while that sounds easy, it's sometimes very difficult. And for those of us that have entered into these types of helping professions, we have a powerful desire to put things right, to heal, to prevent harm, and to promote well-being. What this means is that sometimes when we see someone heading down a path and we consider it to be the wrong path, we can often want to get in front of that person and say, stop, turn back. This is called the righting reflex. But the problem is that this can often have the opposite effect. It's not that people are lacking and need filling up or that they're in denial, but as humans, we have a natural tendency to resist persuasion. This is called the reactance theory. This is specifically true when we feel in 2 minds about something. So I may think that I would like to go for a run this evening, but I know it will be dark and I'll be tired. Equally, I might know that a medication might support me, but equally, I don't like the side effects. We know that it's the person's own motivations for change and not ours that are likely to trigger behaviour change. So our role has to be to support people to voice their own reasons for change. And we need to think about shifting our own behaviour often from teller and fixer to asking and being a partner and a guide. Next slide, please. So I wanted to include this quote because I love it and I feel like it's important here. So the foundations for quality supportive self-management require a shift in the relationship and power between people and healthcare professionals. It also requires us to see people beyond their symptoms, tapping into their locus of control, ensuring that people feel valued as a whole person. Next slide, please. So I'm building on this and thinking differently about supportive self-management. We also know from the evidence that supporting people to build their own health confidence is key to improving population health. Patients not able to manage their own health and well-being see their GP 10 times more a year. But when confidence improves, it's only a matter of time before physical health improves and GP contacts fall. So simple strategies such as asking people how you would rate your ability to manage your health and well-being are really important, and following this up by asking one thing that they might need to help and improve their health and well-being. Next slide, please. If we did this, we would find that about 1/3 of people have high levels of activation. This is knowledge, skills, and confidence, and probably wouldn't need too much other than tailored information about options and quality shared decision-making. However, those people with lower levels of activation, knowledge, skills, and confidence need support to build their health confidence. And there is really good evidence that this can be done through a range of things such as health coaching, peer support, and quality self-management education, all of which are underutilised at the current time. Next slide, please. I wanted to just briefly touch on these three new funded roles within our primary care networks. These 3 roles have training which is underpinned by coaching, by behavioural science, and through shared decision-making. So health coaches are really well placed to support those people with low levels of health confidence. Social prescribers, which I believe Claire and Ian are going to touch on in a minute, are well placed to support people to connect with community assets and support that they might need in terms of social isolation, perhaps in terms of staying in employment or getting back into employment, or maybe support around financial worries. And care coordinators have a really important role to ensure that care is wrapped around a person and their needs. Next slide, please. So I wanted finally, if I have time, and I think I do, just to share with you a journey of change. And while I was preparing for this talk today, I remembered that back in 2016, when I just started a role as self-management lead within Sussex MSK Partnership, I was asked to go and talk at a large MSK conference within an ARMA almost symposium, a kind of section of that conference. So the fact that the service had employed a self-management lead tells you something about the ambitions of that service. And here are some of the slides that I presented showing the aims of what we were looking to do. Key to this was focusing on outcomes that matter most to people rather than the system, and ensuring a focus on supportive self-management. I remember ending the presentation with the slide with a heart in it, which is a flash mob and was meant to illustrate the scale of change. Next slide, please. The change programme, which ran from 2016 to 2019, was multifaceted. And I won't have enough time to go into detail today, but these slides provide a high-level overview of some of the changes that we made. So we really thought about what training and support our clinical teams needed in terms of training and behaviour change, motivational interviewing, and shared decision-making. We ensured there were clinical champions to support that, and that our staff and clinicians had time to reflect on their practice. We also worked with our patient partners, so our experts with lived experience, to think about what people needed to make the most of their experience within the service and the appointments they had. So we created health literate decision support tools. We made sure that people had access to quality health and wellbeing guidance. And we also made sure at the end of each appointment that a person was sent a letter addressed to them, outlining what was important to them, any treatment decisions, and any self-management plan that had been agreed. It was a really supportive system. We really thought about the leadership, and there was a patient who was a director of that service. As I said, I also had the fantastic role of being a self-management lead, and we also made sure we had patient-centered electronic records. So this really prompted the clinicians to think about what mattered most to the individual. In terms of commission services, we had social prescribers that actually worked into the pathway, connecting people to that support across their communities. We had direct access to IAPT, long-term conditions pathways. We had access to health trainers, weight management support, and subsidised gym memberships for those people who needed it. We worked with a local voluntary organisation to support people to remain in work, and we had access to self-management education. Next slide, please. So very quickly, here are some outcomes over those 4 years. We found that people's experience of care was significantly improved. People felt more involved in decision-making. Next slide, please. And we saw a reduction in referrals to secondary care, with more people choosing to self-manage, which is in line with the research that shows if you give people quality options in line with what matters to them, that in the main, people don't choose the most invasive option. And as you've seen in the previous slide, there was many more options available to people than information, do nothing, have physiotherapy or surgery. Next slide, please. So what next? Well, as I mentioned at the beginning, I'm just about to finish, Chris. We've taken on a new role within the supported self-management work stream. And amongst other things, we have a group of people that have come together to think about what great supported self-management looks like. We will co-produce guidance. We will gather together case studies and evidence. We will produce tools to support implementation, and I hope develop a community of practice. So thank you very much for taking the time to listen today, and please make contact with me if you are interested in this area. I'd love to hear from you. Thank you.
Thank you, Claire. It's fantastic, and it's obviously stimulated lots of discussion and lots of questions. So we'll come to the questions after we've heard from the other speakers in this session. So hold on to those thoughts. Just in terms of the questions, I've put in the chat if you want to like those questions, and then we can kind of prioritise those as we go along. I'm going to move us on to our next speakers, Dr. Ian Bernstein, who's a clinical director for MSK Health and a musculoskeletal physician and director of medical education, and Claire Langley, who's clinical lead for the long COVID service, community adult health services. So welcome to Claire and Ian, and look forward to hearing about long COVID and community MSK services from you. Thanks. Over to you, Claire, I think.
Lovely, thank you, Chris. So I'm just going to touch on today my service and how we're working in collaboration with Connect along the way. Can I have the next slide, please? So a little bit about long COVID. It is defined by symptoms that persist over 12 weeks that are not explained by an alternative diagnosis. And you can see on the right-hand side here a range of symptoms. This list is absolutely not conclusive. What I want to really stress on this slide is how long COVID is a multi-system virus affecting physical health and mental health. So it's going right across the spectrum. And most people do recover from COVID in a few weeks. However, people with long COVID who go on to develop it can often relapse and get reoccurring symptoms. Next slide, please. So oiling the cogs and how we've worked out this pathway, there's been much collaboration along the way, as has been echoed throughout this conference today. One of the key to the successes is most providers are on system one. So we have a shared access and we're able to see each other's notes. And what that means is we can do trusted assessments. So if I refer to Connect and vice versa, we're able to take on board that assessment and work with it to reduce duplication. We're able to offer a very holistic approach and individualised care, as been mentioned, working in this manner. We have an MDT, which is hosted by me at CLCH, but in that MDT, it's for all community partners. So we have Connect, we have the Mental Health Trust Foundation, we have the third sector, and that really works well. And what I found with long COVID is it's really broken down the boundaries of traditional models of care. We've been trying to do it for a long time and talking about it, but actually long COVID has really stopped that silo working and given us permission to work across sectors. So it's really quite an exciting and innovative way of working. Next slide, please. So a little bit about the West Herts Long COVID service. We're very much a growing, evolving team and a multidisciplinary team, as you can see on the slide here. We offer a holistic screening and review at 6 weeks. We can offer now one-to-one support in terms of occupational therapy and physiotherapy. And in the team, there's a really strong emphasis on evidence-based practice. So as it's quite a rapidly emerging research base, we really try and keep on top of the evidence to be able to offer our patients the most up-to-date advice possible. And the MDT for that multi-system complex support. As we've already discussed, there's a lot of complex needs with people with long COVID, and to be able to all talk about it in an MDT forum really provides them with the best kind of evidence-based practice and advice possible. Next slide, please. Over to Ian.
Thank you, Claire. So I want to tell you about Owen. He's a 58-year-old residential home manager, and he was sedentary and had some medical comorbidities before he developed COVID. His job is important, as you'll see. He contracted COVID in April 21. The paramedics advised that he could remain at home, but he developed severe fatigue. He took to bed for 3 weeks, and when he did start mobilizing, he wasn't able to go out the house for several months. Now, his physical fatigue is improving, but he has mental fatigue, cognitive impairment, and this has caused a significant problem with him returning to work as he's unable to concentrate. And his lack of improvement has also triggered his depression. So what we're going to see on the next slide is how he might navigate the system that's been set up, the pathway that's been set up. Claire.
Thanks, Ian. So it's quite a busy slide, but it just illustrates how he might come into our pathway. So he would be triaged and have a thorough holistic assessment. And as Chloe just discussed, we would really find out what's important to that person. They would then be offered a range of different therapies, including a peer support, vocational rehab, possibly to help get him to work, and some physiotherapy. And then he would be discharged back to the GP once his goals are met. So this is just an illustration. Thank you. Next slide, please.
So one part of this pathway is the management of fatigue. This is the most common symptom in people with long COVID, particularly those who've been treated who had their COVID in the community and weren't admitted to hospital. So in West Herts, Connect Health is commissioned to treat 500 patients over the next 12 months. We offer a virtual group program with 6 two-hour sessions over 12 weeks. But there's also an option for individual therapy on a one-to-one basis with our clinical psychologist, and this could either be face-to-face or remote as clinically determined. There's an option for patients to switch out to our traditional MSK rehab program if they don't have any post-exertional malaise and they only have mild fatigue symptoms. There's also an option for them to switch into our traditional pain management service if they have prominent myalgia rather than fatigue. Now, the next 2 slides cover how COVID is impacting our community services. So this first slide looks at how COVID is affecting who turns up in our clinics. So at the moment, the effects of COVID are seen in probably 25% of our referrals. So there's a significant cohort of people who held back consulting with their GPs during the second and third waves of COVID, and they want treatment now. There's also a significant cohort of people whose lifestyle has been changed by the pandemic. So social isolation, reduced social contact, reduced sense of purpose, maybe loss of employment, reduced physical activity, have all combined to increase frailty and increase symptomatic osteoarthritis. We've seen a small number of people with impingement type symptoms following vaccine administration, the so-called SERVA syndrome. Interestingly, and I think this is a testament to what's happening in general practice at the moment, GP referrals into our service in West Herts have not yet reached pre-COVID levels. And I think this is because general practice is just snowed under at the moment. And that's probably just as well because our Tier 1 and Tier 2 musculoskeletal services are carrying significant vacancies. This is a combination of the effect of the pandemic and the additional roles reimbursement scheme, which I'll come on to later. So this slide, by contrast, looks at how long COVID is impacting our community MSK service. So we are running the long COVID pathway for people with fatigue, myalgia, and brain fog. The pilot opened last week. First cohort of people are coming through the program. In our general physiotherapy clinics, we think that around 5% of people are turning up with unsuspected long COVID. They've been referred in essentially with problems relating to deconditioning, but on closer questioning, they are likely to have long COVID as a cause of that. Similarly, in the chronic fatigue service, which pre-exists this long COVID pathway, we're seeing about 5% of people with relapses of chronic fatigue, that they had chronic fatigue syndrome before COVID, but they've had COVID and it's triggered a relapse. And similarly, about 5% of the people coming into our community pain management service also have an exacerbation of pre-existing chronic pain, but there are a number of causes for this. A small number of these people have had COVID or had a flare-up following vaccination, but the more common cause is the stress related to the pandemic, which could be loss of employment. It could be a grieving for loss of people who've died or been seriously ill, or post-traumatic stress disorder if they've been in hospital. So multifactorial causes for people in the pain service. We're getting anecdotal reports of an increase in presentation of fibromyalgia in our clinics in Connect Health around the country. And I just wanted to highlight this paper from senior colleagues published in the summer, which shows that there may be a new syndrome of post-COVID fibromyalgia, which particularly affects men and more obese people and those who've had more severe COVID. So keep your antennae out. And finally, in this section, I just wanted to cover the impact of long COVID on the workforce. Well, thankfully, we don't currently in West Herts have any staff off sick with long COVID, so we don't anticipate that long COVID is going to affect our Tier 1 and Tier 2 musculoskeletal services. But it will impact our pain and chronic fatigue services because our staff are being diverted to run the long COVID clinic. We are out to advert for staff for the long COVID pathway. But here's the bind. First of all, we've only been offered a short-term contract by the CCG. The funding envelope is unknown, and that's not without justification. There's every hope that the prevalence of long COVID will be significantly lower in a year's time than it is at the moment. So it's difficult to offer long-term contracts, and therefore it makes it difficult to recruit into the post. And of course, these posts are competing with better paid vacancies in the first contact practitioner roles in primary care. And so, as with many services across the country, we're carrying significant vacancies and finding it difficult to recruit. The collaboration with Central London and Connect has highlighted some training needs for clinicians. First of all, we want to ensure that all our staff, particularly those who are not looking after long COVID patients in particular, are aware of the red flags such as undiagnosed fatigue, breathlessness, chest pain and palpitations, and that they are aware and understand what post-exertional malaise is. All our staff at Connect Health are strongly encouraged to undertake the introductory long COVID training program that was developed by Central London Community Healthcare Trust and is on the e-learning for health portal. This training program is free for all health and social care professionals in the United Kingdom. For our more experienced staff, there are opportunities for shadowing and supervision. And I think Claire's just going to explain a little bit more about collaboration across the pathway. Claire.
Yeah, thank you. And regarding the EL, the online learning, we have just started, nearly finished actually, a advanced module as well. So although this module is for all clinicians, there will be a more advanced module for those in long COVID. Shadowing and supervision, again, is really key in the collaborative pathway. So across Connect, CLCH, and the third party, we've all been observing each other's sessions and really learning from each other. So that's been a really key part. Thank you.
And I think there'll also be an opportunity for clinicians to come to the MDT as well, and there'll be shared learning going
Absolutely.
on in the MDT discussion. I wanted to just touch on health inequalities. The epidemiology of COVID and long COVID are different. So long COVID presents more commonly and more severely in younger age groups, and the symptoms of fatigue, breathlessness, and post-traumatic stress disorder are more common in women than men. But there's also a social gradient. there are avoidable health inequalities in long COVID. It's more common in areas of higher deprivation, and those like Owen who were working in health and social care or had underlying health issues. Now, the importance of vaccination can't be more underlined here. We know that if you don't get COVID, obviously you're not going to get long COVID, but if you do get COVID and you've been vaccinated, the Zoe app suggests that the chances of developing long COVID are around 50% if you've been fully vaccinated, including boosters. Of course, we don't yet know what's going to happen with Omicron, but the data is certainly hopeful. Now, Owen is struggling to get back to work. Claire, tell us how else we can help with that.
So for Owen coming into our service and working with our occupational therapist and vocational rehab, there's really 3 tiers to VOC rehab. And I think Owen would come in on tier 3, requiring specialist support. So under this tier, he might get some support with workplace simulation tasks, the journey to work, and planning a route, and some help really working with his occupational health department and pacing his return to work, and really quite specific advice and support. So he would definitely get a lot of help from our team, and hopefully back to work really soon. So that is a summary of our pathway, and say the absolute key to it has been that collaborative working, not just across Connect and CLCH, but across all the systems. Thank you.
Claire, just to pick up Chloe's point about social prescribers, where would they fit into this vocational rehab pathway?
So for anyone we want to refer to our social prescribers, we have direct links, and I think we would invite them to the MDT or do direct referrals to them. So as well as the social prescribers, we have links with the community navigators who can advise on benefits and support with that. So we've got close links with all providers.
Brilliant. Thanks very much. Chris, back to you.
Fantastic. Thanks, Ian. Thanks, Claire. And it's fantastic that you're highlighting some of the additional challenges that we're going to face going forward. And I think giving us the kind of insight and what's coming down the line and the work you're doing is really, really helpful. Thank you for that. We're going to move on to Sarah Holden and Marie Derbyshire to talk about supported self-management, which links nicely into the last slides from the last speakers. So Sarah is Head of Public Health Services at City Healthcare Partnership, and Marie is the Operational Lead for the St Helens Wellbeing Service. So thank you both for joining us. Over to you.
Thanks, Chris. I think we're just going to get our slides up, hopefully, and we'll make a start. So good morning. Thank you for the invitation to speak this morning at ARMA's conference. My name's Sarah Holden, as you say, and I lead the Public Health Services for City Healthcare Partnerships. I'd like to introduce you today to the St Helens Integrated Wellbeing Service. And my colleague Marie, who's the Operational Lead for Social Prescribing, will be presenting a focus about how we have incorporated social prescribing into the many health improvement interventions, including the escape pain pathway. And we hope the information presented will give some food for thought and inspire you to seek out social prescribing opportunities in your own areas. So next slide, please, Marie. Okay, so we're going to give you a brief background on the Integrated Wellbeing Services, talk about how we've interpreted social prescribing in St Helens and how this fits with our escape pain community model that's been developed in partnership with our local therapy services and the wellbeing team. Next slide, please. So the St Helens Wellbeing Services serve a population of around 196,000. Our town is situated between Liverpool and Manchester, for those not familiar. And as an ex-mining town, our statistics show us in one of the top 20% most deprived local authorities. We have a number of health challenges and a rise in demand for MSK services. Health inequalities means there's a difference in mortality rates of around 9 years between the most and the least deprived wards in our borough. And St Helens is also, though, very ambitious and driven to improve health outcomes, working with patients, and by strengthening our partnerships, working within a wider integrated care partnership known as St Helens Cares, where we aim to provide the right care at the right time. Next slide, please. So this is some of the services that sit underneath just the wellbeing services that form part of that wider partnership. It's clear that evidence-based health improvement initiatives to get active, to lose weight, to stop smoking, and many more that are listed there can be really effective in the short term. But the reality is, without considering the whole person, their situation in life, their housing, their economic situation, their social support networks, many of these health improvement initiatives can fail to be sustained in the longer term due to those wider needs. Our case study today considers some of the key elements to improve those patient outcomes. Next slide, please, Marie. So why social prescribing? So with a conservative 20% of primary care appointments being driven by an underlying social issue, social prescribing can actually be a really useful approach to supporting people to get the right care and support, which is often not solved with a medical intervention. St Helens has taken an asset-based approach to focusing upon the individual strengths and the assets available in the local communities and networks to help people to improve their wider outcomes. This approach helps clients to focus upon their own personal situation, the wider holistic needs, and connects them into a range of support and services. The goal plans are person-centred and owned, and importantly, help that client to move forward, gaining confidence to self-manage. The evidence base is growing for the effectiveness of social prescribing, and the impact of COVID has encouraged us to think of new and innovative ways to continue to engage with our clients. Social prescribing being at the forefront of those discussions, and then incorporating the wider pathways of the various health improvement interventions and wider connections into community services. So I'll pass you over to Marie now, who'll tell you more about how we're developing social prescribing in St Helens.
Thank you, Sarah. So I wanted to look at what is social prescribing. So as you can see there, it is a holistic approach, and we're working with people to improve their health and well-being. So we'll look at what their goals are, how they can take control of their lives, looking at their needs and interests. So we link people up with services, but it is always, as Chloe was saying before, it's about what matters to me. They are absolutely at the centre of that support. So we'll look at things like housing. We have a dedicated member of the team who works with our local social housing provider. And we will also look at things like anybody having financial concerns, issues around debt. We have a member of the team who works within the Department of Work and Pensions, and they will provide things like benefit advice provision, employment and training, and linking them with that support. Obviously, isolation can be a key important issue, and we will connect people and support their emotional well-being. So looking, you can see from that diagram there, lots and lots of links are made with a variety of local services. Somebody may be referred for mental health support, emotional and psychological support. For example, something like CBT. It may be that our link workers are working with somebody around general housing and debt management. Those needs may be very complex, but sometimes they're not. Sometimes it may be as simple as joining somebody to community groups to engage with local activities. It may be that they are lonesome and they want to link with somebody to have a simple coffee and chat, befriending services, or they may want to learn new crafts, new skills, and it's all about making those social contacts and connections. So when somebody comes through into our service, when we have a referral from MSK, it will come through to our frontline team who will thoroughly triage somebody in a holistic way, and then they will be guided through that pathway. So initially they may see a lifestyle advisor who will speak to them about becoming more active and supporting them around specialist exercise. It is absolutely a co-production, and all services wrap around the care of that individual. So you can see there from that diagram, as I've said, it is absolutely wraparound. Sarah's already touched on some of these services that St Helens Wellbeing offer. We have that partnership with MSK and primary care. We also have our link workers working specifically with people to support, as we've said, around those. It's a professional relationship, and it's providing that support both socially, and this is delivered over the phone, virtually or face to face. And again, it's about giving that person choice. So obviously through COVID, we didn't have as much choice, but we're starting to build that back into the support that we can offer people, that extra choice. So this can be up to 12 months. We can work with people over 16 years of age. The team will map the client's needs and utilise a database that we have of over 300 community services, and it's just growing all the time. The team will explore that support and help that person to make those connections. Some people can make connections easier than others if they have higher levels of confidence and self-motivation. However, those others need a little bit more hand-holding to guide and support them through that. So the short-term support, it could simply be that somebody needs referring into a service such as citizens advice or help with their housing, or it could be that they require, you know, that 12-month support along with that relationship building. So, as we've said, it is a co-production. It is about that long-term sustainable change. So we will look at a tailored exercise program to manage pain. We will educate and support on a weekly basis, and we will support people to build in things, coping strategies, things like mindfulness techniques. It might be rest and ice, and very much appropriate exercise. Again, as we said, we're looking at those wider determinants to run alongside all of this support. We can refer to our local mental health services, and we have specifically set up a course with our local provider, Think Wellbeing, who have devised a course for St Helens Wellbeing clients to support with their long-term conditions. And again, it's a service for anybody 16 and over. We can support around anxiety and depression and the long-term condition. We will assess somebody through our assessment tools. We will assess their PHQ-9 score and GAD-7. We will look at those. However, if those still don't meet the threshold, our team will specifically look at that individual and decide whether that extra support is required. Within that team, we have 2 psychological wellbeing practitioners working with us, and one of our wellbeing service representatives is also as part of that group to make sure that it is holistic and we're keeping in touch with each other. So I just wanted to look there at a client journey. So this is a typical client journey, and we have 48-year-old female, as you can see. She was previously extremely active. However, very sadly, she was struggling with chronic knee and hip pain. So the referral was made into the escape pain course, and we looked at that holistic, looking at all the wider determinants. This particular lady was unemployed. She had low confidence, as you can see, and self-esteem, and she was really struggling to enjoy other pursuits. So all these factors, as you realise, you know, they are interdependent. So following 12 months, you can say happily the outcome was that she was able to exercise. She received that support and education around her condition. Her pain and function and mental well-being and quality of life all improved, and she maintained her exercise plan. And subsequently, her confidence and self-esteem vastly improved. Unbelievably, she returned to work in part-time employment in a very physical role as a cleaner. So what a marvellous outcome for this particular person. And you can see their typical feedback of how the support was received by the patients. You can see there other feedback from social prescribing interventions delivered by our link workers, and you can see how things, you know, have typically affected around finances. Some people don't know what they're entitled to claim, that they're frightened, they're embarrassed, and we can support them to get to the right benefits and realise that that help is there to support them through this difficult period. And you can see again, you know, some people have said to us very sadly, you know, that they felt useless, but coming through our service, having the support of social prescribing and our link workers and the wider team has absolutely empowered them to make those life changes. And lots of feedback like that, especially over COVID. Just to show a few outcomes there, so you can see where the escape pain participants were involved, their pain, function, quality of life and mental wellbeing scores vastly improved. Looking at the national figures there, you can see a 76% retention rate over 2018-19, and locally we were recognised as gold standard with our model and that lovely 94% retention rate to support those people. The Health Innovation Network looked at cost saving over 2.5 years based on 29 clients coming through that service, and you can see a marvellous almost, you know, £44,000 saved over that period. We have some links there, as previous speakers have said, that people can access to look at what support and help is available. More information around social prescribing, and I'm sure that these slides will be shared at the end of our talks this morning. So you can take a look at those if you'd like further information. So we just want to say thank you so much for listening this morning. You can see our contact information there, and you can see at one of our events when we brought all our teams together, the lovely big team that we have over in St Helens, who work to support people around those wider determinants of health. So thank you very much for listening.
Brilliant, Sarah. Thanks very much, and beautifully timed as well. Thank you. And really interesting to hear about, you know, what a wraparound service you offer. What a great intervention that's client focused, but also, you know, bringing benefits for financially as well. So a fantastic intervention. So thank you to all our speakers for that session so far. We're now moving into a Q&A session for the next 25 minutes or so. So we've had a host of questions in the chat, so I'll pick through the questions and allocate to each of our speakers, if that's okay. So first one is around the components of personal care being very accessible. This is from Laura Atherton, as a clinician leader who really appreciates the importance of personalised care and true collaboration with people with lived experience. Currently, systems are working in silos, and this impacts on the ability to bring about change in personalised care. There are often parts of the system saying we already do this, and the biggest barrier when it is evident that they're not doing that. So I'll go to Chloe first for this one. What are your top tips to help facilitate and embed this approach to become business as usual for us?
Thank you, Chris. So we are really lucky across systems to have input from our personalised care group within NHS England. So we have some really fantastic support, and we have some regional leads to help us to do this. But of course, we need to start where people are at. And if you remember in my presentation where I talked about behaviour change and the provision of new information not being enough to facilitate behaviour change. So in my experience, what we need to do is to really understand across services with the leads and the clinicians and the people that all work in those services, really start to understand what matters to them. What is it they're trying to achieve? We really have to make sure that we believe in their experience. So not to say to them, look, this is a different way. So really understand what are their current challenges, and to seek to, you know, understand those. And then absolutely, once we build those trusting relationships across teams, we can provide evidence, and there is growing evidence that the core components of personalised care can really support us now to get those changes that we need. So in essence, I suppose what I'm saying is seek out the support across your systems. It is there in terms of embedding personalised care, but seek to understand what matters to services in the same way that you would do if you were working with an individual to support behaviour change. Build those trusting relationships, build on people's strengths and motivations, and that's the way that we can support transformation, really, and this different way. One final point, I will be quiet in a minute, is really utilise those people with lived experience. Co-production is key here. Listen to people's experiences of care, really involve people with lived experience in designing services that people want and need rather than what we think they should have. And we've got, I know, a number of people with lived experience on this call here who are really skilled in co-production. So yeah, that's my response to it, Chris.
And Christine is going to be your friend for life as well, Chloe, you know, after that. I was going to ask the same question for Marie and Sarah. And Marie and Sarah, can I ask you to put your cameras on for the question session as well? That'd be great. Thank you. So I don't know, Marie, if you wanted to go first.
Yes, I think that, you know, it is, as Chloe was saying, you know, listening to people and what their needs are, and not telling them what is required. And, you know, I think that's the lovely thing, that when you're part of that co-production and the integrated teams that we have, there is lots of help that somebody can very quickly be signposted onto, so they don't have to go through referrals to service after service. We can very easily signpost people straight through to the services that they require. And it seems to build confidence as well, because it's all there for them and they feel that somebody's listening to them.
Sarah, did you want to add to that?
Yeah, just a couple of points really. I agree sort of with the previous comments. I think it's about knowing your communities, and I think about knowing what fits, about understanding the challenges that people face, and I think the presentations have probably drew some of those messages out this morning. I think it's about sort of thinking about strategically in your borough as well, and your areas, about, you know, your ICP priorities and systems. How is the system working together? And we all understand how complex these things can be. So how, as a strategic function, can we remove some of those barriers as well, whilst listening to the people who are using those services and getting their voices fed into that system as well, and that discussion. So it's about removing barriers, I think. Thank you.
Yeah, thanks all. I'm going to go on to a question about health literacy. So it's just basically, how can we help to improve health literacy, which has come across as a big issue for in all of the presentations and from Steve this morning. So I'm going to ask that of Ian and Claire to start with. So Ian.
So I think this is a societal problem. This is much wider than just, you know, the caring professions. So, you know, this starts in school and making sure that this is in the curriculum, dispelling myths, making sure that people have got the ability to decide what is a trusted source of information. Everybody's exposed to social media and lots of online sources, and what they need are the skills to be able to determine what is a high quality source of verifiable information, and what is people just peddling myths and peddling on people's uncertainties and insecurities. So there's a huge role in the curriculum in schools, public health campaigns. The problem is that unless people, it's very difficult to just put information out there. It's just like our own learning. If we're not interested in it and it's not relevant for us, it just passes us by. So I suppose from the health professionals' angles, things like MEC, making every contact count, is a really important touch point. Most people will see a health professional at least once a year, and that touch point is an opportunity to raise health education and awareness beyond whatever the person is presenting with. And I think making sure that people are skilled in delivering MEC is really important. Claire, anything that you want to add?
I completely agree regarding the MEC, and all of the clinicians in our team are kind of trained to that standard. So we really do make every contact count. I think also, just to add, in the new year, we really want to do some kind of outreach work, whether that's going into GP surgeries, into faith groups, just to really get that information across to those harder to reach groups. So yeah, I think it's a bit of a two-pronged approach.
And I think, there are some examples of good success with outreach programs. So the Flipping Pain program is gathering steam in Lincolnshire and out in the West Country in transforming general public's view of what chronic pain is, and that it's not just a medical condition, it is a wider biopsychosocial problem, and that we need to understand people's context of pain rather than just the pain itself. So, but it takes a huge amount of effort to put these public health programs in place, but it can be successful.
And I think, just going on what Chloe was saying about co-production and getting service users to kind of be embedded in that process will really help address some of those issues.
And I think that speaks to Christine. Christine has put in the chat around finding community champions and those with lived experience partners that reflect the communities that we're working in. I'm sure Marie and Sarah, you'd probably agree with that. Did you want to come in and say anything about the health literacy question, how we help to increase that? Anything to add to what Ian and Claire have said?
Yeah, no, I completely agree. My keywords were sort of champions and advocates and people from communities who are often much stronger at delivering a message than perhaps we can be. I think there's something about consistency and simplicity of messages as well, because there's so much out there, and it's often quite difficult then to understand which is the right information so I can make a decision for myself. So I think that's really important. And I think trust, I think that was picked up earlier in the presentation, building trust in the messages and where to go for those messages. So, yeah.
And I think that highlights, Chris, an important point, which is multiple channels of communication. There's no one of these things is going to solve the problem. We need multiple channels of communication, multiple ways of reaching people.
Absolutely, and as well as multiple.
Do we?
Sorry, I was going to say, as well as multiple, again, it's been echoed throughout everyone's presentation, but it's collaboration, that multiple partners are all saying the same or similar messages. I think that is really key here.
Yeah, thanks all. A question for Chloe in terms of measuring behaviour change and the impact. So what recommendations you have that we can, data is a problem for us in MSK. We know that that's a challenge for us. So how do we measure the so what, Chloe?
And this is such a brilliant question. And again, it goes back to what we know about behaviour change, is that we sometimes focus on the change prematurely before people are ready, willing and able. And we know that supporting people to get to the point where they want to change the behaviour is, once you get there, that's the easier part of the journey. But what we're not able to do at the moment, what we don't do, I think we are able to do it, we don't consistently measure the journey that gets us to the change. So how do you measure somebody's growth in health confidence? And I touched on that in my presentation. How do we start to measure the changes in people's beliefs, in their attitudes, in their subjective norms? There are really good tools to support us to evaluate that. And I think that will be really helpful for clinicians as well, because if we see that part of the journey as really important, and we focus on that, we're not then going to jump ahead of people's readiness. But if we always focus just on behaviour change as the outcome, we won't provide or create enough attention on the things that are prerequisite to that. So building trusting relationships. So in terms of measures, they are out there. Really, measures of shared decision making are really fantastic, because we know from the literature, if people are involved in decision making, that is a direct predictor of whether or not somebody goes on to change. So what I suppose in summary, I would say, try to move away from just focusing on the change and think about all the stages and how we measure the stages that get us to that point. But yeah.
Great, thanks. Marie and Sarah, do you want to come in?
Yes, thanks, Chris. I think it's about, as Chloe was saying, looking at those, it being centred around the person, their goals, having those tools, looking at milestone appointments. So, I know our link workers will constantly check in with people at certain key points, and it's about that celebration of achievement of the goals and then progressing on to further goal setting.
And Sarah?
Yeah, just to come in really on that preparation, that time in advance and that journey somebody goes on. That's a conversation we have in quite frequently, really, as we review our own performance metrics about how do we actually measure the difference, and rather than it just being sort of those numbers, the journey that somebody goes on is hugely important to understand how we shape services as well for the future, because unless we understand how difficult it will be for each individual, and every journey is different, how we can flex the systems to make sure that we can meet the needs. That journey, I think, is just what we're trying to sort of get to grips with. I think at the moment, so we tell the story quite often of our clients and how they've come through services and been supported, rather than just looking at the numbers, although the numbers are still important and we don't want to move away from them completely. I think the journey is equally as important. So understanding that, trying to get measures and consistency in how we demonstrate that going forward is important.
Yeah, great, thank you. There's a question, it was specifically for Claire, about embedding third sector in the MDT, but there's a couple of things in the chat about working with independent sector as well as third sector. So I think as a general question, how do we kind of look more broadly and more collaboratively, I guess, across the different sectors to embed this? And it kind of speaks a little bit to what Ian was saying about this being a societal challenge. So I'm going to come to Claire first. So how do we how do you embed third sector, and how do you recommend that we do that with independent sector and other partners, Claire?
I think it's about raising awareness of what's out there, because this has really opened my eyes to what services are already out there, and it's just connected them. So all of the team are aware of the community navigators, for example, the social prescribers. We have the Charity Mind attend our MDT as standard, just to, again, it's really about sharing that learning and experience. But we're by no means there, and where we are today looks completely different from where we was a year ago. So I think we're going to continue to learn, and any suggestions really of people who have been to these groups and embedded, we've got a long way to go still, but we are getting there. And I think the key has just been really increasing our awareness and that willingness for the collaboration.
Thanks, Claire. Ian, did you want to come in?
I don't think anything to add.
Okay, thank you. Sarah.
Yeah, my couple of points on this. I think one has been about, I suppose Marie touched on it in our presentation, just around our link worker role isn't just client facing, working one-to-one. It's about going out into the community and understanding what services and assets we've actually got, how do they work, and vetting, I suppose, to a certain degree to make sure that they're suitable for clients to then be able to access in a safe way. So mapping and developing the database really of assets in our communities that we can then use ourselves and share with our colleagues and our partners and strengthen the partnership. So there's something about mapping and understanding what we've got, And then how do we build capacity in our systems so that others can do the same, because that sort of MEC approach can be really then helpful, that others are doing the same. So perhaps they didn't go in our link work, have the conversation, but if they go and speak to their therapists, then they're telling them the same message. So we're reinforcing sort of the similar and standard messages, and encouraging people who may be lacking in confidence to engage. So I think that's really important. I think that's probably, yeah, there was probably something else there as well. It might come back to me in a minute, but yeah, mapping into
no worries, that's great, yeah. Thank you. Chloe, did you want to add anything there?
Well, I absolutely agree with everything other people have said. And I think what's interesting in the model I shared with you from Sussex MSK Partnership is actually they invested in working with their community partners. So a charity who was really well placed to support people to remain in work. They also invested with another community organisation to make sure social prescribers were embedded in the pathway. And we saw the cost effectiveness of this within the slides that I presented, that there was significant cost savings because we were able to offer people a broad range of options in terms of supported self-management. Often what we found, and as I said, in line with the research, is that people don't choose the most invasive, most costly treatment. Often people choose to self-manage. And we saw, as I showed, a £7 million saving across the 4 years, which can then be invested in those other really good evidence-based interventions that are currently underutilised. So yeah, that's a couple of thoughts from me.
Yeah, thanks all. I'm going to go to another question from Bernadette, I think, about how will clinicians be trained to adopt the language of pain within the concept of personalised care. Bernadette shared her experience of having had a spinal injection and then the nurse saying afterwards, it's all cured now, you're going to be fine type thing. So it's about that kind of broader embedding around the language that we use, I guess. So I'm going to come to maybe Ian first. That's all right.
So this is really an issue about professional training. And the first step is recognizing that you've got a learning need. And so that can be difficult for somebody like the nurse in this example, who may feel that, you know, she's working very well at the top of her license and offering good empathic care, and maybe trying to, you know, put a hopeful spin on things, but without realizing what she's saying, how that's affecting the person or the patient. So that's where appraisals come into place, because your appraiser may be able to see your case presentations. They may be able to run through case discussions with you, observed consultations where someone is watching you. They may pick up the language that you're using. There are curriculum tools that may highlight areas that perhaps you're blindsided on, and you don't know that you've got a learning need. But I think the first step is identifying that you've got a learning need. And so, as we've seen in this example from Bernadette, feedback is really important. I mean, all the professions now have 360-degree feedback embedded in the professional registration, but I suppose making it really work and taking notice of it. So if that patient had actually filled out a friends and family test feedback form regarding how they felt about that comment, that might have been fed back to the nurse concerned. I think I'll stop there.
Chloe, have you got a hand up? Well, you've gone yellow. I'll come to you anyway.
Oh, I hope not. Yeah, I mean, this is so important, and I think it essentially goes back to what we've been talking about across the presentations this morning, is about how do we have different conversations with people. And we've already heard for people living with chronic pain, that pain is just one of the things that people are living with, and sometimes we focus on that in isolation. So it is about having different conversations with people. It's about really seeing people, as I said, as having strengths and opportunities, working in partnership with people. And essentially what that means is really being able to offer quality shared decision making, really being fantastic at building trust and rapport. And I want to just highlight that we do now have the Personalised Care Institute, which provides free online training in personalised care approaches. And I would really advocate for people in whatever role you are in, whether that's in health, social care, or a voluntary and community provider, or in fact someone with lived experience as well, please do look at the Personalised Care Institute for that training, because I think it can be really helpful in helping us reflect on our own practice, and really starting to think about, you know, the changes, small changes perhaps that we could make that would change the dynamic of the conversation. So yeah.
Thank you. Marie, did you want to come in on this one?
I think it's mainly just to agree with what other people have been saying around about training for people, so that we're all constantly kept abreast of having those conversations. So yes, just to agree really.
Okay, thank you. There was another question which kind of links into this, which was around peer support, and around, you know, healthcare professionals' attitude to peer support, which I'm taking was a kind of suggestion that it wasn't a very healthy attitude to peer support. So the question was around how we can improve healthcare professionals' attitude to peer support. So I'll come to Ian first, and then Sarah.
So I think professionals' attitudes can be mixed. I think at Connect Health we work with a number of colleagues, patients who have had very wide experience, people like Peter Moore, very wide experience of treatment in the NHS, and are really able to help us as clinicians understand the patient's perspective. And of course, they are absolutely fantastic at explaining and helping patients navigate the system and really bring personalised care to life in a way that I have to say is often better than I can do it. But the reason that sometimes it's mixed is that sometimes some patients who are working in that capacity may be trying to push a particular theory that they have, or right a particular wrong that happened to them, and they're going off at a tangent and not looking at the broad picture. So we then get feedback from the patient groups that they actually didn't find that peer group helpful. So it is mixed, and I think you know, just as interactions with a health professional are mixed, as we've heard today, and so, you know, people's experiences being reflected in that. All we can do is to try and, you know, work to improve the standards of support that we're offering. And I think, you know, understanding what personalised care is, I think our peer supporters need to be trained to do that well, just like the clinicians need to do it. And I'd be interested to hear what resources are available to support the peers to be able to do the peer support.
Thanks, Ian. I'm coming to Sarah. Sarah, I'm going to give you 1 minute before I wrap up, otherwise Sue will be on my back.
No problem. Well, very quickly, peer support, hugely valued, I think, in terms of the work that we're doing right across integrated wellbeing services. I think in terms of how we can improve that, I think we need to show examples of how it's working. We need to demonstrate that. We need to talk about it. We need to find the right forums to take those examples of where it's working really well. And just to touch on, I suppose, the standard side of it, you know, we have things like volunteer coordination within our remit. So we will bring volunteers through an Investor in Volunteers standardised programme, and then look at the competencies for peers and volunteer support in the communities that they're going to work with as well. So I think having some of those standards is really helpful, sort of to raise the bar and to I suppose strengthen the messages when you are going out to talk to professionals.
That's brilliant. Thank you. Chloe, you've got a hand up, but I'm not going to let you say anything. Sorry.
Oh, okay.
I'm really sorry, Chloe, and I'm really sorry that we've got to draw this session to a close. It's been a brilliant session. So I'd just like to thank everybody, all our speakers so far this morning, on behalf of ARMA and the conference. It's been a really stimulating session, some great questions. I'm sorry we didn't get to answer all of those, but thanks all for your input. I think we'll taking a short 10-minute leg stretch. I'm going to get out of my boiling hot broom cupboard just for 5 minutes, and we'll